The topic was about oligometastatic disease in solid tumors. And as has been published in many mainly retrospective studies, it seems so that local ablative treatment would improve the prognosis of oligometastatic disease. And recently there have been randomized controlled trials, phase 2 prospective trials that have confirmed that is the case. And my topic was so we are at the beginning of the treatment of metastatic tumors, if they are oligometastatic, with ablative treatments in order to improve the prognosis in a stage where the patients do not have any symptoms. Usually, or conventionally, radiation is very successful in palliating metastatic symptoms or symptoms coming from metastases. But the relatively new avenue is that we are treating metastases in order to improve the overall prognosis. And then the question is, how can we measure that? Of course, the overall goal or aim is always to improve survival or to prolong survival preferably without any symptoms. But we have to have some intermediate endpoints to measure whether the treatment has worked. And there, one of the interesting things is that what we measure with systemic treatment, there is an intermediate endpoint called progression-free survival, and that's measured as progression of the disease during treatment or on treatment, and then this is a signal that the treatment is no longer working. And this is also used for studies with ablative radiation. But there is a significant and a noteworthy difference between systemic treatment and local treatment for metastases, which is in the nature of the treatment, namely that it is systemic. So going everywhere in the body. So by definition, if there is progression of a tumor on treatment while there is systemic treatment, then all lesions that are newly appearing or are getting larger are exposed to the active agent, which is not the case for a local treatment, be it surgery or be it ablative radiation or radiofrequency ablation. That doesn't matter so much, because the local treatment, of course, is only going where it is targeted to go. Therefore, progression of disease as the appearance of new lesions is different here, because the lesion that is newly appearing has not been exposed to the active agent. And therefore, the proposal was that a more adequate or more oncologically adequate endpoint would be the failure of a local or local-only strategy. This would be in my opinion, the oncologically more sound endpoint for studies to measure whether the treatment is still effective, as in contrast to progression-free survival. Because then if you consider a patient with one metastatic lesion, say 2 centimeters in the lungs, and another lesion that is not yet visible on imaging, just let's say 1 millimeter, so you cannot see it, And this patient is, well, the larger lesion is treated, is ablated with stereotactic ablative radiotherapy. And then some 3 or 6 months later, the patient shows, or there is growth of the already present, but still very small and below the detection threshold lesion, and that is then treated in a second session. This patient would, in a study, have experienced progressive disease due to the newly appeared lesion, whereas if the same patient would have the 2 lesions just a bit more close to each other, the one, let's say, is 2 centimeters and the other one is 8 millimeters, then both would be visible and both would be treated at once, and there would be no progression at the next and the following follow-ups. So this illustrates, I think, what is the background of that thought. And at the bottom of all that is, I think, we have to realize that tumors are, well, growing or too quick, or too fast, but still they are growing relatively slowly. They have if we think about the tumor volume doubling time, so how long does it take for a tumor to get to double the volume of a lesion or of the cell mass? Then this takes typically for metastasis and for patients that we treat with locally ablative treatment, typically this takes about 3 months, 2 to 4, roughly 3 months. And that means that it takes quite a long time for a single cell stage before a lesion becomes visible, because it's necessary to grow to almost 1 billion cells before a lesion is visible at, say, 8 millimeter diameter. That's about roughly a third of 1 billion or 1 billion cells. So if there is just one cell seeding a metastasis and that grows to a visible metastasis, this takes 27 times the tumor doubling time. And that is about 6 years, which is quite some time. It's not that we treat metastasis now and prevent new metastasis from appearing 3 or 6 months later. That's biologically not possible. And so there is always the invisible part that is more important in tumor growth and also in the treatment of cancer. And that's very relevant for the project to treat tumors locally. And that's called the parallel progression model of tumor growth. There's also another model where it is supposed that first there's a primary tumor, and then the metastases grow later, and then a metastasis again makes seeds a new metastasis. And this would assume tumor doubling times that are much, much, much faster and much too short, in contrast to what we can measure in the clinics. You can measure that on an ordinary CT scan by just taking the diameter and assuming the metastasis will be a sphere, and then you can calculate from one to the next date how the tumor volume doubling time, how many months that takes.